Welcome you all in the learning portal of Sanjay Gandhi Postgraduate Institute of Medical Sciences. Myself is Dr. Sanjoy Kumar Sureka, working as an assistant professor in the Department of Urology. Today I would like to talk about a brief overview of prostate cancer. So during my presentation, I will share my viewpoints about basic anatomy and physiology, why prostate cancer is important for us, that is the disease burden of prostate cancer. I will also talk about pathophysiology, presentation, the diagnostic modality, as well as staging, treatment options, and finally I will give you a take-home message. So I will come into the basic anatomy of prostate first. Prostate is a accessory male sex organ, which is a walnut size of approximately 15 to 20 grams. If you see into the image on the right hand side, you can see the prostate, which is located just below the bladder, and it surrounds the urethra and located in front of the rectum. The function of the prostate is to produce white color fluid, which is added 20% of the volume in the semen, that is 20% of the seminal fluid. If we go into in depth of anatomy of the ejaculatory duct, which is an important part of prostatic anatomy, the ejaculatory duct is formed by the union of the vas deferens and seminal vesicle. If you can see on the right side of the image, and the ejaculatory duct finally open into the prostatic part of the urethra. It crosses the prostate. For better understanding of the prostatic disease and the prostatic anatomy, the prostate has been divided into 3 zones. On the, if you see the image, there is the upper image. You can see the ejaculatory duct entering into the prostatic urethra, and this surrounding zone, which is surrounding the prostatic urethra, you can see here in the lower image, is a transitional zone, and there is a central zone, and the majority of the prostate is formed by the peripheral zone. And the common non-infectious disease of the prostate, as we know, is one is BPH, that is benign prostatic hyperplasia, and other is prostatic cancer. The BPH involves the transition zone of the prostate, that is, it's the zone which surrounds the urethra, and prostate cancer involves the peripheral zone. So as you can see in this image, that is the lower image, and even the cancer can extend beyond the prostatic capsule and may involve the neurovascular bundle which remains on the posterior inferior aspect of the prostate. Now I will talk about why we are discussing prostate cancer today, that is how the burden of the prostate cancer in worldwide scenario as well as in Indian scenario. Worldwide, prostate cancer is the second most common cancer in male. If you see the left-sided image, that is this image, you can see the prostate cancer forms around 13.5% of the 13.5% among all the cancer in worldwide in males. However, in India, this is the 5th most common cause of prostate cancer related mortality. Now I will talk about the prostate cancer burden, that is the incidence of prostate cancer in worldwide scenario as well as in Indian scenario. First, I will talk in worldwide data. So it is the second most common cancer in male, whereas it is the fifth most common cause of mortality, as you can see on the right hand picture in worldwide data. Whereas in India, it is among top 10 cancer, and the incidence is increasing in most of the major cities. As we came to know by the data provided by Global Cancer Conference in 2018, that the incidence in Indian population is 9 to 10 per 1 lakh population per year. And the maximum incidence is in Delhi region. Now I will talk about pathophysiology of the prostate cancer. The prostate cancer is a multifactorial disease, as like other cancers. The exact pathophysiology is not clear, but the possible risk factors which has been described in context of prostate cancer include age, there are certain dietary factors, there are certain lifestyle factors, there are few genetics factors has also been described, and most importantly, the prostate cancer is an androgen dependent cancer. That means the testosterone has a profound impact in causation of prostatic cancer. And the most common risk factor is age, and prostate cancer is usually seen in more than 55 years of age. It has been seen in the autopsy findings that in male more than 18 years, 80% of them has focus of prostate cancer. In dietary factors, animal fats, low fruits and vegetables has negative impact in the causation of prostatic cancer. In genetic factors, which is a very complex subject, but there are few important genes among more than hundreds of genes. If I talk about is like BRCA, that is BRCA gene 1, BRCA gene 2, which has been also described in context of breast cancer. And if there is a history of prostate cancer in first degree relatives, which also increase the incidence of prostate cancer or increase the risk of prostate cancer by twofold. If I talk about the pathology of the prostate cancer, 95% of the prostate cancers are adenocarcinoma. And other rare histologic types include small cell carcinoma, transitional cell carcinoma, squamous cell carcinoma, neuroendocrine tumor. It is interesting to know that the presentation of the prostate cancer varied widely, and it depends on the stage of the disease. And majority of the prostate cancer which detected by PSA screening are usually asymptomatic. In locally advanced disease, a patient may present with obstructive or irritative voiding symptoms like intermittent urinary stream, decreased force of the urinary stream, hematuria, hematospermia, that is blood in the semen, and obstructive uropathy, that means obstruction in urinary flow, which may lead to acute or chronic renal insufficiency. In more advanced disease, when the lymph nodes are involved, patient may present with edema in the lower extremity. In metastatic disease, the symptoms of presentation related to the site of the metastasis. Since we know the bone is the most common site for the prostate cancer metastasis, so majority of the metastatic prostatic cancer patients present with bone pain and sometimes spinal cord compression symptoms related to destruction of the bones, which leads to paraparesis. The diagnosis of the prostate cancer again depends on clinical examinations, certain blood investigations, and I will also talk regarding the images which may help in diagnosis and staging of the prostate cancer, and I will also talk about the biopsy of the prostate, which is the confirmatory test for prostatic cancer. In clinical examination, the most important clinical examination, which can give you clue regarding prostatic cancer, is digital rectal examination. That means we put the finger in transrectal route and we try to palpate the prostate, which is situated anterior to the rectum. It provides information regarding the size of the prostate, the consistency of the prostate, the surface of the prostate, that is, surface is regular or irregular, the overlying rectal mucosa. If the prostatic cancer is locally advanced, it may involve the rectum also. So we can understand this if the rectal mucosa is fixed. And if the prostate is tender, we can understand that this may be related to some prostatic infection. The classical findings in prostatic cancer in DRE is hard nodular prostate, but this is usually found in advanced stage of the disease. The digital rectal examination has a low sensitivity, approximately 50%, however, decent specificity of approximately 80%. Next is PSA. PSA is a very important aspect for prostate cancer diagnosis as well as prostate cancer screening. PSA is a serine protease glycoprotein which is secreted by posterior epithelium. It is prostate specific, but it is not cancer specific. The normal value of PSA in male is 0.4 to 4 nanogram per ml, and this value depends on many factors like size of the prostate, age of the patients, and it has a sensitivity of 70% and specificity of 90% to detect prostate cancer. Again, the sensitivity is on the lower side as we have seen in DRE. So there are lots of hue and cry we have encountered or we have seen regarding screening of prostate cancer with PSA over last 1 decade. As of now, the current recommendation is that the population-based screening should not be done and not recommended. However, patients with high risk factors like family history or some genetic disease which may increase the risk of cancer, who are in 40 to 54 years of age, they should have screened with PSA. And normal men with 55 to 69 years old should not be screened routinely, but they should offer PSA screening, and also they should inform regarding the advantage and disadvantage of PSA screening, and that is known as shared decision making. So we can do PSA in this age group of 55 to 69 years old men. However, they should be well informed regarding its pros and cons. Patient with more than 70 years or life expectancy less than 10 years, screening has no role. So if I summarize the role of DRE and PSA. So in a patient who are say for 60 years, if we do a DRE and a PSA, and if DRE is normal and the PSA is normal, no further action is required. We may repeat the both after 2 to 3 years. However, if DRE is normal but prostate is PSA is high, then they should be investigated further. And if PSA is normal but DRE is suspicious, then also they should investigate further with imaging modality plus minus biopsy. Now I will talk about the role of MRI in staging evaluation of prostate cancer. MRI has come up in a big way over last few years in prostate cancer diagnosis. It is definitely superior than CT scan for local staging because it has a better soft tissue resolution and it give you minute details regarding involvement of the prostate cancer into the surrounding structure like neurovascular bundle, rectal wall. It also helps in determining whether prostate cancer is involving the prostatic apex or not. It better delineate the periprostatic fat involvement. And recently, the role of MP-MRI has come up in a big way, that is multiparametric MRI, which helps in decision making for biopsy in doubtful cases. I will talk few words regarding role of MP-MRI in the diagnosis of prostate cancer. When the PSA is between 4 to 10 and patient having a normal rectal examination, this area of PSA, this zone of PSA is known as the gray zone. There may be prostate cancer, there may not be. The incidence of prostate cancer in this gray zone varies between 20 to 30% in Indian scenario. So in this group of patient, before going to biopsy, we can do a MP-MRI, and based on T2 weighted MRI images, ADC values, and dynamic contrast enhancement pattern in MRI, prostate imaging reporting data system has given 1 to 5 grading. If the PIRATE score, that is prostate imaging reporting and data system grading score, is less than or equal to 2, we can omit biopsy. We can follow up the patient with repeat PSA after a suitable interval. However, if the PIRATE score is 3 or more, then biopsy is indicated. The role of CT scan in evaluation and management of prostate cancer is not so great as I described regarding MRI. It has its own limitation. However, it has better sensitivity and specificity to assess the pelvic lymph node metastasis. It has a big role for planning of radiotherapy in the setting of prostate cancer. Because CT scan lacks the soft tissue resolution, so intraprostatic anatomic change due to primary tumor, capsular extension and seminal vesicle extension cannot be determined with certainty and inferior as compared to MRI. The most important aspect of cancer diagnosis is prostatic biopsy. The prostatic biopsy is usually carried through transrectal route. In early 1990s, the open or finger guided biopsy has been popularized initially. However, with availability of good ultrasound, now transrectal ultrasound guided prostatic biopsy is the standard of care. In the past, 6-core biopsy was commonly done, which include one core from base, mid-zone, and apex in the both lobe. Currently, the standard biopsy is 12 core transrectal biopsy, which we say as trans-guided biopsy. And as we can see in the image, the 2 core to be taken from base, mid-zone, and apex in the both lobe. Coming into pathological grading of prostate cancer, the pathological grading of the prostate cancer has been first described by Donald Gleason in 1966, and subsequently International Society of Urological Pathology has standardized it in 2005, and they have described the Gleason grade from 2 to 5. So far the prostate cancer pathology is concerned, the grade 1 is most well differentiated prostatic gland which is not cancerous. So 2 to 5 is from well differentiated to very poorly differentiated prostate cancer. This scoring system has been further modified in 2016, and the final prostatic Gleason grade is made on the basis of adding the most common pattern plus the second most common pattern. That means if in a prostate cancer specimen, the most common pattern is 3 and the second most common pattern is 4, then the final Gleason score would be 3 plus 4, that is 7. With better understanding of prostate cancer pathology, now it is well accepted that while reporting prostate cancer, the minimum grade should be 3 plus 3, that is 6. Below 3 plus 3, that is 2 plus 2 or 2 plus 3 or 3 plus 2 should not be reported, as they are insignificant in relation to prostate cancer management or prognosis. So now prostate cancer final score has been divided into grade group 1 to 5. The 1 is 3 plus 6, 3 plus 3, that is 6, and 5 is 4 plus 5 or 5 plus 4. Now I will talk few words regarding the metastatic workup of prostate cancer. In past, the chest X-ray of the pelvic bone or spine was a very important investigation while doing metastatic workup for prostate cancer. But with advent or availability of better imaging like CT scan, MRI, the popularity of chest X-ray or X-ray of spine and bone has reduced. But the most important investigation for evaluation of the prostate cancer metastasis is technetium-99 bone scan, which can detect with good positive predictive value regarding the prostate cancer metastasis in the entire skeleton system of the body. And now PET scan also been added in the basket of metastatic workup imaging of prostate cancer. I will come in details in the subsequent slide regarding the role of PET scan or its current utility in relation to prostate cancer evaluation. As I said, that 99 technetium bone scan is one of the most important investigation, and it is a standard of care for standard recommended image for evaluation of the bone metastasis in the setting of prostate cancer. As you know, that most common site of metastasis in approximately 80 to 85% of the patient of prostate cancer involves bone. So it can detect bone metastasis with good sensitivity and specificity. The most common site of prostate cancer metastasis is vertebral column and followed by pelvis, then ribs, femur, shoulder girdle, etc. In the right side image, you can see there is multiple mates in the throughout the skeletal system involving the whole of the most of the spines as well as pelvic bones. The PSMA, that is prostatic specific membrane antigen PET scan, is more sensitive to detect bone metastasis as well as soft tissue metastasis as compared to bone as well as CT scan. However, it has its own limitation, like it is more costly, it is not widely available, though it is available in our center, but probably in Lucknow, we are the only center who is doing PSMA PET scan. And since it is more sensitive, it sometimes detects more soft tissue or bone metastasis, which probably does not have any impact on management plan. But there is the main advantage of PSMA PET scan is that it is a single investigation by which you can survey the whole body to find out any metastasis present or not. Whereas if you are doing a bone scan for bone metastasis, you may need to do another imaging like CT scan or MRI for find out the soft tissue metastasis if you are not doing a PSMA PET scan. So that is one major advantage of PSMA PET scan. However, in the current scenario, the PSMA PET scan is not the standard investigation for evaluation of metastasis of prostate cancer, though it is widely used by the urologists throughout the world. TNM staging of prostate cancer is like other cancer. It has been divided into T, N, and M staging system. The T1 is clinically inapparent tumor. That means there is a tumor within the prostate, but it is not palpable by rectal examination. Usually they are detected by screening PSA evaluation. And T2 is the tumor which is confined within the prostate. However, they are palpable by rectal examination. T3 is the tumor when the tumor extends through the prostatic capsule, and in T3B, when the tumor invades the seminal vesicle, which is important to know because it has impact on surgical treatment modality or treatment pattern in the context of prostate cancer management. T4, when the tumor is fixed to the adjacent structure, which may be rectum, which may be pelvic bone, which may be pelvic sidewall muscle, etc. In nodal class staging, N1 is the regional lymph node metastasis, that is the metastasis within the pelvic lymph node. And in M staging system, M1 is metastasis to non-regional lymph nodes, like say for paraortic lymph nodes in context of prostate cancer. And M1B is bone, and M1C is other visceral metastasis like liver, lung, etc. So I'll now describe the management of prostate cancer briefly. The management of prostate cancer varied widely, and which include no treatment to radical treatment like radical surgery, radiotherapy, hormonal therapy, chemotherapy, immunotherapy. So there are so many options in the basket for treatment of prostate cancer. But each and every modality has its own place in terms of stage of the disease, and so and many other criteria which determine what should be the ideal treatment modality for individual patient. So the decision making for the treatment modality depends on age of the patient. That means if patient is, say for any patient is more than 80 years or older, so radical surgery is usually not preferred modality. When the life expectancy is less than 5 years for a patient with multiple comorbidities, then definitive therapy may not be required, because that may unnecessary uh, for the patient, because patient may anyway live with a localized prostate cancer for more than 5 years without any treatment. And performance status has also important criteria for decision making of prostate cancer treatment. Patient with a good performance status can be offered surgery, radiotherapy, and all kind of treatment. However, patient with a poor performance status may not tolerate radical curative therapy like surgery, radiotherapy, or so on. So, for the better stratification or better understanding or better decision making, localized prostate cancer has been classified in 3 risk group: low risk group, intermediate, and high risk group, which I will come in the subsequent slide. And very important aspect of decision making for prostate cancer treatment is shared decision making. That is, all treatment modalities, pros and cons, which is suitable for the patient, should be discussed with the patient, and then the final decision should be taken. So for this stratification of localized prostate cancer, as I said, that they are stratified in very low risk, which is earlier it was a part of low risk category, intermediate risk, and high risk based on PSA values, stage, and Gleason score. So if I come to subsequent management in risk stage wise, in very low risk disease, definitive surgery or definitive therapy is not indicated, because majority of the patient survive without any treatment for more than 10 years. So in very low risk disease, the treatment options are active surveillance with a life expectancy of more than 10 years. And if the life expectancy is less than 10 years, then only watchful waiting. That is, you will give the symptomatic treatment whenever it's required. Regarding active surveillance, I will come in subsequent slide. In low risk patient, that means when the PSA is less than 10 with a low Gleason grade, the treatment options are wide, which include active surveillance, radical prostatectomy, and radiotherapy is also an option. However, the preferred options are either active surveillance or radical prostatectomy. In intermediate risk group, the most commonly given treatment or the preferred treatment modality is radical prostatectomy with extended pelvic lymph node dissection. And in this risk group, radiotherapy is an also important treatment modality with good cancer-related cure rate. In high-risk localized disease, again the radical prostatectomy and radiotherapy both are good treatment options. However, there is no role of active surveillance in this high-risk localized disease. As if you see the previous slide, even in intermediate risk patient, in a very selected group, active surveillance may be an option. However, in high-risk localized disease, active surveillance has no role. In locally advanced prostate cancer, that means which prostate cancer beyond the prostatic capsule, then the treatment options are radiotherapy is the most preferred modality along with androgen deprivation therapy, that is hormonal therapy. However, with a better understanding of the surgical anatomy and availability of the robot, now people are doing radical prostatectomy in the setting of locally advanced prostate cancer. But you have to understand, or patients should understand, that here the radical prostatectomy is a part of multimodal treatment. That means you have to do radical prostatectomy. Subsequently, patient will require or may require adjuvant hormonal therapy plus minus radiotherapy. So now I will talk few words regarding radical prostatectomy. Radical prostatectomy is a challenging surgery, and it can be done by open laparoscopy or robotic approach. Of late, in last maybe 10 years, the robotic radical prostatectomy has been really popularized worldwide, and it has definitely reduced the morbidity as well as the difficulty level of prosthetic surgery from surgeon's point of view. However, if you talk about the outcome of radical prostatectomy and compare them with all three modalities, the oncological outcome are more or less same. The continence, that is urinary continence following radical prostatectomy, is better in early postoperative period with robotic radical prostatectomy or robotic approach. However, at 6 months, the continence rate is same across all three modality. But the major advantage of robotic or laparoscopic surgery as compared to open is the blood loss. Because robotic surgery or laparoscopic surgery is being done with a pneumoperitoneum, that is with the carbon dioxide within the abdomen. So there is a raised pressure within the abdomen that reduces the venous blood oozing during surgery. So this is a major advantage for using robot or laparoscopic modality while doing robotic prostatectomy. And for the surgeon, robotic prostatectomy is a boon, I would say. It has a very smooth and short learning curve as compared to open or laparoscopic approach. It has a very good vision and very good precision for surgical dissection as well as suturing. I'll share a small video clip so that you can understand how the vision and precision of dissection during robotic surgery. If you see, this is just incision given at the starting of the surgery. You see the precision of the surgery and the movement, precision of dissection with the robotic instruments and the vision. So this is just a small clip. Now we'll come to the management of metastatic prostate cancer. This is one area of prostate cancer which is really challenging, frustrating, and most importantly, when patient reach in the stage of metastatic prostate cancer, the prostate cancer is no more curative, and patient eventually will die, maybe by 2 to 3 years with the prostate cancer. And this is a really bad disease to have. The early and intermediate prostate cancer has good outcome. However, the metastatic prostate cancer has really bad outcome in long term. So I'll just like to talk a few words about the natural history of the prostate cancer. If you see this image, in a localized disease, the prostate cancer can be managed with local therapy. Subsequently, when it becomes metastatic disease, the most important aspect of the treatment is ADT, that is androgen deprivation therapy. We also say as hormonal therapy. And subsequently, this metastatic prostate cancer become castrate resistant prostate cancer. That means they do not respond to hormone anymore. And eventually, this patient, they die within a year or two once they reach in the stage of castrate resistant prostate cancer. So the management of metastatic prostate cancer is largely depends on androgen deprivation therapy. That is the castration. That is, we want the testosterone level to be very low or minimum, because as I already said in the pathophysiology, that androgen and testosterone has a profound impact on prostate cancer etiopathogenesis. And it is a testosterone or androgen dependent cancer. And this castration can be done by surgical, by like bilateral orchidectomy, or can be done medically. Now, lots of androgen agonist as well as antagonist are available in form of oral form, or injectable forms are also available. So the many wide range of androgen, anti-androgen medical options are available nowadays, which can be offered to the patient. Just I would like to mention an important fact that Huggins got Nobel Prize in 1966 for understanding of this effect of hormone in prostate cancer. And he described that prostate cancer is hormonal dependent, and doing orchidectomy may cure the prostate cancer. And for that, he received Nobel Prize, and he is the only urologist who received Nobel Prize for this invention till now. But over last 1 decade, apart from ADT, other additional therapy has been available for the management of metastatic as well as castrate-resistant prostate cancer. Though the androgen deprivation therapy is the mainstay of management of castrate-resistant metastatic prostate cancer, however, the novel agents like abiraterone acetate and chemotherapy like docetaxel, they are also being added in combination to androgen deprivation therapy to get better response in metastatic setting. And when patient become castrate resistant, that is castrate resistant prostate cancer, these novel agents are being used like abiraterone acetate, enzalutamide, or chemotherapeutic agents for treating the castrate resistant prostate cancer. So with availability of these agents, the quality of life and survival has improved to some extent. Unfortunately, the metastatic cancer is not curable. The median survival of metastatic cancer in Indian scenario is approximately 3.5 years, which has been studied from our institute and has been published in Indian Journal of Medical Research in 2018. So I would like to conclude my presentation with few take-home message. The prostate cancer is a common cancer and with a rising incidence in major metro cities. But hope is that it is a slow growing tumor, and most of the tumors are detected in early stage, and they can be detected by prostate specific antigen test, which is a simple test done with the blood of the patient, and further evaluation can be done with available imaging system, and the diagnosis confirmed by biopsy. The prostate cancer treatment varies depending on the stage of the disease and many factors as I described. And localized disease can be cured with surgery or radiotherapy also. However, the metastatic disease can be treated effectively with hormone therapy and chemotherapy with significant increase in survival and better quality of life. However, they are not curable. So awareness about options available for prostate cancer diagnosis, management is important to know, so that patient can be referred to the urologist in a timely manner for better outcome. Thank you so much for your patience hearing.